The next presenter, that is Dr. Tiruveedhi Yaswanth, Management of Malignant Glaucoma after TRAP in eye syndrome with microspherophakia.
Yeah, namaste and good evening everyone. So I want to present today about the malignant glaucoma after trabeculectomy in ICE syndrome. So regarding coming to my case, 19 years old female from Andhra Pradesh, visited at first time in 2019, complaining of both a diminution of vision, which was gradual and progressive in nature since 6 months, associated with pain and redness. There was no any history of trauma or medication usage or systemic diseases. And when coming to the ocular examination, at the time right eye, her visual acuity was 20/100, improving only up to 20/40. And iris conjunctiva was clear, cornea was clear, but anterior chamber was shallow with iris showing the atrophic changes. And when coming to the pupil, it was irregular, sluggishly reacting to light and polychodia, and lens was clear, and we have found microspherophakia and dilatation. And IOP with GAT at 2:54 p.m. it was 34 millimeter of mercury, and on doing the gonioscopy there was a two angles closed with goniosynic and peripheral anterior synica was noted. On fundus examination there was an retinal pigment epithelial hyperplasia with bone spicule pigmentation around the superior arcade vessels starting near the disc with 0.7 cup disc ratio with sloping rims. And central corneal thickness was 540 microns and the axial length was 21.61 mm and specular count was 1700. This is regarding the right eye. And when coming to the left eye, best corrected acuity was the 20/30 and the anterior chamber was shallow with atrophic changes, and the pupil was same like right eye, sluggishly reacting and polychodia with microspherophakia and dilatation. And the intraocular pressure was at 28 millimeter of mercury, and one angle was closed and goniosynica was seen. And fundus also same like in the right eye, there was an RPI hyperplasia with bone spicule pigmentation with 0.7 cup disc ratio. Corneal thickness was 530 microns and axial length was 21.42 and specular count was 1900 cells per mm square. So we came to the diagnosis of both eyes iridocorneal endothelial syndrome, both eyes microspherophakia and both eyes Yaswanth syndrome. So we started with, as IOP was high, we started with 2 AGMs and we called after 2 weeks, but patient lost to follow up and again came with pressures of 24 and 22. And after 6 months again patient came, so we augmented the AGMs and all the complaints was stressed. Still the patient was unaware of what's happening, although I explained everything, and patient came after 2 years with IOP of 24 and 26. So finally I advised trabeculectomy for both eyes. So after left eye trabeculectomy, intraocular pressures came to 10 plus or minus 2 millimeter of mercury with a moderate height, elevated blood and doing well. After right eye trabeculectomy, since post-operative day 1, anterior chamber was very shallow with the peripheral lenticular corneal endothelial touch with the intraocular pressures of 11 plus or minus 2. Cerebral test was negative. I suspected a malignant glaucoma and I started cycloplegics and aquasuppressants and other post-operative medications were started. After 1 week, as there was no improvement, UBM was done and finally we concluded as in malignant glaucoma, and we planned for pars plana lensectomy and core vitrectomy. And post vitrectomy patient was doing well with intraocular pressures of 12 plus or minus 2 millimeter of the mercury. So when coming to the pathophysiology, although poorly understood the pathophysiology behind it, which is involved an alteration in the anatomical relationship of lens, ciliary body, anterior hyaloid phase and vitreous, which results in forward movement of the iris lens diaphragm. And UBM mainly it helps in both diagnosis and the monitoring the therapeutic response in eyes with malignant glaucoma. It demonstrates the rotation of the ciliary body, marked displacement of structures of anterior segment, peripheral iridocorneal touch, and forward shift of lens may be noted by using the UBM. And B-scan may be used to rule out other causes of flat anterior chamber such as suprachoroidal hemorrhage or choroidal effusions. And OCT may be used as a non-invasive technique for monitoring any anterior chamber narrowing in the affected eyes. So treatment strategies, if we follow, if for example in the phakic patient, if we do the cataract extraction with posterior capsulotomy and vitrectomy, and in the pseudophakic or aphakic patients, if we do the NDIAG laser capsulotomy and finally the vitrectomy surgery, the outcomes are very good only. The main thing is that we have to never forget the management of the fellow eye. So after an episode of the malignant glaucoma in one eye, there is a high risk of this complication occurring in the fellow after a surgical intervention. And patient should be warned of this when consent is taken for surgery on the fellow eye. prophylactic measures, including the cessation of the miotic drops and prolonged use of atropine after the trabeculectomy surgery, and preoperatively prophylactic laser peripheral iridotomy, all should be done as a prophylactic measures. And these methods will help maintain the normal anatomical position of iris lens diaphragm and reduce the risk of aqueous misdirection. So I want to conclude that malignant glaucoma continues to provide a therapeutic challenge which probably reflects our limited understanding of its etiology. Whatever the true mechanism, the fact that is relieved when a direct communication is made between anterior chamber and vitreous cavity support the theory that lens, anterivitreous and ciliary process are intimately involved in the pathogenesis. All eyes with primary angle closure glaucoma should be closely followed, particularly in the early postoperative period following the glaucoma dryness surgery. If a patient develops malignant glaucoma in one eye, preventive measures should be taken to prevent occurring in the fellow eye at the time of surgery, and prognosis of this condition is good with currently available treatment modalities. Thank you.
Right, thank you. You are Yaswanth,
Yes.
yeah? Okay, we don't know your name here.
Indian spelling is Sai.
Yeah, it's a full name. Yeah.
Okay. So tell me something, how did you diagnose spirophakia?
So on dilatation, there was a journals was not in proper, and there was a gaps will be founding. So
Where? In the zonule?
in the journals.
Is that the only criterion? Did you see the refraction of the patient? What happens in spirophakia? What is the refraction of the patient?
So it was improving with plus. It was improving.
No, I'm talking about at presentation.
Yeah.
The refraction was not very myopic.
Yes.
Spherophakia has to have a degree of high myopia,
High
not
yes.
just myopia.
Yes.
So how, I am a little confused how you diagnose.
Okay.
Anyway, that's beside the point. The second point I want to make is, you did a lensectomy with the
Yes.
pars plana vitrectomy.
Yes.
Is it possible to do lens sparing surgery without actually going posteriorly?
Lens sparing, actually it was iris. The lens is.
Or in other words,
yeah.
let me rephrase that. Is it possible to do a cataract? Well, it wasn't cataract. A clear lens extraction and approach the vitreous anterior hyaloid phase is what you want to disrupt.
Yes.
Anteriorly.
Yes.
Then you could have saved the patient from becoming aphakic.
So in that case, actually, the lens is almost touching the endothelium. So
Doesn't matter. You use mannitol. I have done many cases. You use mannitol, use cohesive, good quality, cohesive viscoelastic, make space.
Okay.
That is not going to require phaco power.
Okay. Yes.
It's only going to require lens aspiration. So then you could have, aphakia in this day and age is mutilating surgery for a young patient like that.
Yeah.
It can be approached anteriorly. You can do, and you've not given that procedure, irido-zonulo-hyaloidovitrectomy.
Yes.
Can malignant glaucoma, you call it malignant glaucoma, I don't like to call it malignant glaucoma, I call it aqueous misdirection. Can it recur after pars plana vitrectomy?
No, chances are less after pars plana.
What do VR surgeons do? They do a core vitrectomy. They don't come up to the lens. Of course, they sacrifice the lens here.
Yeah.
So here it won't recur.
Yes.
Okay? But if you don't come up right up to the lens, and I am primarily talking about lens sparing surgery, meaning you take out the crystalline lens and replace it with an implant.
Okay.
Yeah. Okay? What that patient will now need is a sclerofixated IOL.
Yes.
Okay?
Yes, sure.
Thank you.
Yeah, thank you.
Yashwanth, one question. Why was there spicules or something you mentioned in the fundus? Some pigmented spicules you mentioned in the fundus, or did I get it wrong?
Yeah, it's Yaswanth syndrome was there for that patient.
So it's a feature of that.
Yes, right.
Anti-hyalotomy can be done. Anti-hyalotomy.
So you can use a retractor, create a PI, then go further down, do a zonulectomy, and then turn your retractor towards the posterior capsule,
Yes.
disrupt the hyaloid phase, and do a primary posterior capsulectomy with the IOL in position.
Thank you very much.
Yes.